It's a great pleasure to be here. This is the second time I've participated in this conference, and it's always interesting that when they ask for historian, they ask the oldest guy in the room to begin and talk. And what I'm going to do is give you a perspective on history. I'm going to start off with the most historical, Egypt and the Talmud and Victoria. So the next slide, the Talmudic writings. 4,000 years ago, in the Talmudic writings, they said if a woman has two children who died of circumcision because of bleeding, none of the rest of her children, boys, need to be circumcised, which is an enormous religious issue in terms of Judaism. 1,000 years later, they did something even more clever. They said the following: if the woman has a single child who died of bleeding at circumcision, and her sister had a boy who died of bleeding of circumcision, neither women needed to circumcise future boys. So they understood the genetics of hemophilia 3,000 years before any gene testing was ever done. Next slide was Egypt. Now, the Egyptian papyruses clearly show hemophilic arthropathy. And it's very interesting. They didn't call it that, but they were clearly seen. And the next slide after that is really to talk about Victoria, which you all know better than I do. And only recently did they find out that she was actually a carrier of 9, and everybody for years thought she was going to have 8 deficiency. And many of you also know that the Spanish dynasty exists the way it is now because one of the heir apparents died as a auto racer, and another because he was shot in the war. And certainly we know about the Russian Revolution. So we'll go on, and next is, what do we really know about the history of the management of this disease? Well, if you went back before you get to the next slide, in the Russian Revolution, it's really interesting, Rasputin's influence was mainly because he was a hypnotist. And most of you would not know, in America in the 60s and 70s, auto-hypnosis was a major therapeutic modality to get people not to have pain. And it fell out of fashion, and yet was extremely good. Wally LeBeau in the Midwest and the people in Philadelphia actually wrote a lot about this. Okay, so now let's look at what was used for infusions. Let's start off with direct transfusion. The earliest literature is father to son on a table, even though they didn't understand anything about mismatch or any of that. That's how they transfused people. Next, FFP. Now, next slide. Let's talk about FFP. Fresh frozen plasma was used because it was in the 40s, during the Second World War, that Ken Brinkhouse was the first person to say that what was missing in hemophilia was a plasmatic factor. He had no idea what it was. He didn't call it factor 8, he didn't call it factor 9, and it coincided with the institution of blood banking. Blood banking began in the Second World War, and they could actually draw blood, spin it, and make plasma. FFP was the standard of care, and when I trained in both Rochester and at the same time in Boston, Massachusetts, they actually delivered plasma to the home of hemophilia children and gave them transfusions. Why was it stopped? Transfusion reactions, and surgical intervention was impossible because of plasma volume overload. Next slide, which is cryoprecipitate here. Cryoprecipitate, 1962, Judith Poole, a blood banker, woke up one day and found in her basket somebody had thrown away a unit of fresh frozen plasma, and at the bottom she wrote she found there was a mush, which means there was crap at the bottom of the book. And she spent her entire career unraveling that and said it was factor VIII, fibronectin, and von Willebrand's factor. It was the standard of care for a long period of time. But the most important part of this, it was the use of cryoprecipitate that got a father of a hemophilia patient in Texas, who happened to be also a manufacturer of freezers, to have a friend who made cryoprecipitate for his son, but he infused the child and froze the cryoprecipitate and began for the first time. And when they moved to Chicago, it was written in the New England Journal of Medicine, the first home infusion program for hemophilia was with cryoprecipitate. The ability of home infusion began the concept of hemophilia treatment centers and comprehensive care, none of which I'm going to go into, but if you really want to read about it, in March of last year, there is a major piece on the evolution of comprehensive care and hemophilia treatment centers. Following that, the next slide, what did you get? You had human-derived factor concentrates. And you could not have done it without cone fractionation, which was a pretty smart guy at Harvard who said, I can make globulin and I can make fractions of plasma by a process of fractionation. And because of that, the first factor VIII concentrate was made in, well, I don't know why this is going on and on.
I think the lights are outside.
What?
I think the lights are outside.
Oh, somebody is playing with it. Oh, it's all right. It's fine. They actually made factor VIII in Sweden, and it was the Swedish factor, and I'm not going to go into all the history, the famous history of the Allen Islands, but it was Inga-Marie and Margareta Blumbach who went with the first factor VIII concentrate, which was a plasma-derived von Willebrand containing product, which they didn't even know that was what was in it, and went and showed for the first time that the kids that were dying from bleeding, the women, which was new, even though von Willebrand called it pseudo-hemophilia, they showed that you could cure the entity by infusing this material. And the way they did it was looking at correction of the PTT and the bleeding time, which was the standard of care at the time. Next slide. Following the whole era of human-derived, plasma-derived products was the entry into recombinant factor products, which is really the result of the transfusion-transmitted diseases, which we'll talk about briefly. And as you all know, recombinant concentrates is now the standard of care in your country, not necessarily in my own. Now, let's talk about what we know. Transfusion-transmitted disease was recognized as early as 1976, when there was a major meeting in Washington supported by the National Hemophilia Foundation and the NIH, and we recognized hepatitis B, and we understood about transaminitis. We did not know what it was, but we called it non-A, non-B hepatitis. So if we have the next slide, Hep B, actually a Nobel laureate from the Aborigines in Australia, found the antigen for hepatitis B, And it was hemophilia plasmapheresis material that made the first antibodies. The ELISA tests came from it, and the vaccines followed that great work. Today, hepatitis B is a non-existing issue for our hemophilia patients, but when they tested all available products in the 70s, when Hep B was actually described, 100% of all the concentrates made at the time were Hep B antigen positive. They had virus in it. So 95% of the patients had Hep B antibodies because it's naturally our bodies fight that, and only 5% were B antigen positive, which it was still a problem at the time. And as you well know, it's still a major issue for hepatocellular carcinoma, et cetera, in certain parts of the world. Next slide. HIV. One could spend days telling you about the HIV crisis, but the bottom line is the U.S. was plagued more than any place else in the world, and that's because our concentrate was made at the time with about 60,000 donors. And when the concept of AIDS, which was defined in 1983, was that was more exposure to foreign people than any other contact, which, if those of you might not know, but the fast-track gays, which was the first group defined to have HIV, they had the average of 1,000 sexual contacts a year. And nobody could believe that the hemophiliacs in one vial had 60,000. So when one recognized that, it was no shock that in America, 95% of the hemophiliacs were infected with HIV, and only the VWs who had plasma only, they had 30%. Next slide. Hep C. And I'm not going to go into all of that either, but all over the world before 1985, 100% of US and most countries' patients were Hep C positive. And the reason for that is we had no screening, and it's much more common in the general population than we possibly thought. And no one was doing transaminitis testing for donors at the time, except in New York when they recognized the disease. Next slide. Hepatitis A was thought never to be transmitted, and yet there was an epidemic of Hep A that did occur in the 80s, which was a leak in the whole system and has never been reported again. Next slide. Parvovirus has been a very difficult virus to get rid of. It was common in patients like sicklers who were transfused with red cells, and what we used to call aplastic crises, which we thought was due to sickle cell, was actually parvo infection. And now, with NAT testing, et cetera, parvo is no longer an issue for products. Next slide. And here I'm going to say almost nothing because you all lived through CJD, and the next slide, new variant CJD, more than anybody else in the world. So you know all about it. But the most interesting thing now is the advance is you can measure new variant CJD in blood. And that has only been in the last year or two. I'm just going to take a little water. I'm trying to do this in some fast fashion because they only gave me 25 minutes for a New Yorker. That's very hard. Next slide. Now, this is really extraordinary, and I would think that someday a Nobel Prize will go to the guys in the New York Blood Center who came up with the concept of SD inactivation of HIV. And it's very good for Hep C as well. And let's look today NAT testing is done on blood donors in a lot of the world, but believe me, not everywhere. And if you leave the confines of the, I would say, the developed world, there are many places where blood donation is not tested to the degree that you all are used to. Heat, solvent detergent, and vapor were all done, and that was also a major discovery at Scripps Clinic when they actually found that HIV was rapidly destroyed by heating, and that changed the entire concept of both plasma and recombinant materials that we now know. And it's very interesting that in a place like the United States, we do not have any virally inactivated FFP or platelets. So I just give you an idea that not everywhere has really totally eliminated the transmission of viral entities which we use every day of our life in managing patients with hematologic and non-hematologic disease. Next slide. Now, what are really some of the most important issues that we face? One, prophylaxis. Prophylaxis was introduced in the 50s by Ingeborg Nielsen and Aki Alberg, because Alberg wrote for the first time in the 50s that if you look at the difference in arthropathy in hemophilia patients by factor level, once you get above 2%, you change the entire figure of hemophilia. Ingeborg Nielsen said, then let's get people to be close to that. And that's the entire beginning of prophylaxis. And one, again, could spend hours on prophylaxis, on how it's done, whether tailored prophylaxis versus mandated, rigid prophylactic regimens, we don't know. And as I go through some of the things that are going on now, the paradigm of prophylaxis as we know it today is going to dramatically change when we have different products that might be used subcutaneously that have very long half-lives, despite some of the issues that they also bring. The quality of life, there are tons of tests that have come out now and assays for the quality of life. And I can tell you that there's lots written. You have to be very cautious on short-term clinical trials in which they tell you there's a major improvement in the quality of life. The placebo effect is enormous when people go on new therapeutics. But there's no question that when I started, homeschooling was common, lack of formal education, lack of people attaining their ideal goals in life academically and family were totally different from what you all are used to today. And therefore, you don't need a test to say that the quality of life of hemophilia has markedly changed with time. Next slide. HIV remains an issue. The treatment for HIV is markedly advanced. The compliance with medications and the complications of medications are real, and there are still many patients, and I don't know about in England or London or in this area, that have had major issues because HIV is not controlled. Next. HCV has essentially recently had an ability to be treated. Now, clearance of HBV is about 95% of people clear HBV with antibody. Only about 10 to 20% clear HCV. Therefore, they're left with the residual of HCV. And one of the real issues is at the beginning of HCV therapy with interferon, before they added ribavirin and now the new medications, only the mild cases were treated, and people with severe disease were not eligible. Now, with the new medication, people with even cirrhosis are being treated. And one of the things that one has to be very cautious, and there'll be lots of talks here about gene therapy and transaminitis, etc. Many of those people have cleared HCV, but we have no idea the status of their liver at the time they entered the study. And we really don't know yet whether or not HCV plays a role in the transaminitis of this entity. Next slide. Now, the combination of HIV and HCV. Now, think about in the US and many other countries where 95% were HIV positive and 100% were HCV positive, and many of them had concomitant disease. If you look at that group of patients, the most common cause of death was not infection, but liver disease. The infected liver with HCV and HIV on top of it markedly increased the rapidity and the level of deterioration of the liver. Elaine Eister wrote a wonderful paper on this and showed the difference when you had both versus one. The next slide is really one of the things that we are seeing, and it'd be very interesting to hear from some of the senior hemophilia treaters how much hepatocellular carcinoma you're actually seeing, but we're seeing a fair amount of it in the doubly infected hemophilia patient who is still alive. So it's a very real issue. Piero Minucci was the first person to write about this because he had a flurry of cases, and it has turned out the longer they live, the more likely they are. And let me tell you, early detection is difficult, treatment is difficult, and mortality is not uncommon. Next slide. Inhibitors. One could spend, again, a whole day telling you about inhibitors, but the most important pieces of that you have to look at as young people is, despite everything we know about predictors of inhibitor induction, when a baby with hemophilia is born, with or without a family history, whether it's in severe or not, and I'm not going to tell you all about the likelihoods of developing it, there is absolutely no predictor as to who will develop an inhibitor. Some of the most interesting work, which was shown yesterday in London from the work of Dr. Reipert, is now a real possible marker for this is high affinity IgG3. May very well be a predictor of inhibitors, and there was a lot of discussion about it. On the other hand, inhibitor management is really a major issue. Hello?
This is the BBC.
Ah. Well, if I go on BBC, that's okay too.
Sorry, it's louder than you.
Well, controlling technology is definitely out of our hands.
It's out of mine.
Okay. And the whole management issue of inhibitors, and the one thing I will tell you, and I'm going to reiterate it later, the concept that you may very well have, and I don't know whether it's yet licensed in England, I think it is not, but the ACE910, which is really quite an extraordinary drug for some patients. There's been a lot of talk about how you may not need to do ITI anymore because we have this great wonder drug. Well, I can tell you that the consensus of treaters around the world so far, and I don't know about England, is that eradication still remains #1 priority. And don't be duped into the thinking that a good therapy, as they did when FEBA was introduced, as they did with 7A was introduced, that it's a panacea, and it's not. It is another bypassing agent, and go for converting the patient back to a hemophilia patient without an inhibitor. Next slide. Just a list of everything that's been done in the literature. But I think for those of you who are new in the field, the first one is what you want to look at. Antigen overload is what ITI is about. Where'd it come from? The rabbit. The rabbit that gets an antibody can be the antibody can be eradicated by giving constant exposure to the antigen that caused the antibody. That's what led the Germans at Bonn to do the first work on ITI, immune tolerance induction, and it's successful in major studies anywhere from 60 to 65% using recombinant, and some other studies as high as 80% using plasma-derived VW containing factor VIIIs. And I'm not going to spend time on the SIPPET study and the controversy about using plasma versus recombinant, because then I get into the nitty-gritty of individual patient management, which I don't want to do. The next slide. Gene therapy, and I'm going to have a few slides at the end. And at the same time that we're talking about inhibitors, induction, prediction, and management, we're also worried about the fact who's going to be eligible for gene therapy. And unless you are a native hemophilia patient, a patient with an inhibitor is not ever going to get gene therapy. It's another good reason to bring the kids with inhibitors back to regular hemophilia. Next. Okay. Another way that medicine is being looked at for hemophilia, and I'll talk about some of the other studies in detail because TFPI, tissue factor pathway inhibitor antibodies, because these are now looking at not actually replacement therapy, but substitution therapy, where people are looking at ways to alter the coagulation mechanism in a hemophilia patient to possibly reduce spontaneous bleeding. Next slide. Extended half-life. Again, we're talking about individual products. I do not want to say anything except that the factor VIII extended half-life materials have not been hugely successful because they really don't extend it very much. On the other hand, the 9s are very, very promising and may very well alter what one does about gene therapy. Next slide. Let's talk about ACE910 and inhibitors. It was published in the New England Journal, and the studies for non-inhibitors have just started. And the big issue is, yes, for some people it gets down to 0 bleeds. The general number of bleeds are still higher than what you get in a non-inhibitor patient on prophylaxis. The issues really around this more than anything else has been the serious adverse events. And the serious adverse events, and I can't go into all the details, have been 3 TMAs and 2 major thrombotic episodes. Next. So the question I'm going to ask you is, what is your threshold for adverse events for you to decide who should get what therapy? Next slide. Thrombosis is 1, 2, TMA, 3, and the next product that's on substitution therapy rather than a replacement therapy has been the enormously interesting science behind lowering antithrombin 3, TFPI, anti-TFPI lowers TFPI. the ACE 910 skirts the need for 8, and it doesn't do it exactly like 8, does it normally, and Lenting's paper has shown that. And Alnylam has lowered antithrombin 3 to levels of 15 to 20%, and they have had a death with thrombosis recently. So these are the threshold abnormalities. I think the last slide is what I say is hemophilia therapy is at a crossroad. And why is it a crossroad? Because what we as treaters for years have known as the standard of care has been replacement, prophylaxis, hemophilia treatment center for management of the total patient, and learning to get the patient to integrate into society. Now we're talking about substitutive therapies, many adverse events, and a hype because of subcutaneous treatment. And the question is, you young students of hematology, you're the ones who are going to make those decisions in the next 10 years. All I can tell you is beware. Beware of the hype, beware of the data, and make judgments based on good common sense. And with that, I thank you for your attention.